Welcome to today's Tuck Alumni Lifelong Learning, or TAL, faculty briefing with Professor Rob Shumsky. Today we're going to be discussing putting COVID-19 to the test, research and responses from MHCDS. And I am so excited to invite Professor Shumsky today. Professor, thank you so much for being here. We're very happy to be hearing about all the cool things that the MHCDS program has been doing in your research as well.
Thanks, Renee. Thank you, Renee and Amanda. Thanks for inviting me to do this presentation. It's great to see you all virtually. I hope at the end we have a chance to maybe catch up a little bit and talk and review some of the things that we're going to talk about today. So as Renee said, we're going to be talking here about COVID, which I know has been on everyone's mind. In particular, thinking about the response to COVID that people at Tuck have done, that people in the MHCDS program have done, and some of my own research on this topic. For those of you who don't know, the MHCDS program is the Masters in Healthcare Delivery Science program. It's an all Dartmouth program. It's a joint program between Geisel and Tuck. I co-directed and I teach operations management in that program, it's been a wonderful experience. And just so I know some of the MHCDS our alums are here, and I know it would be great to sort of cross-pollinate between what's going on at Tuck and what's going on at MHCDS as well. I'll also, of course, talk a little bit about my research as we go along. So this really is intended to be an interactive session. I know it's hard to do that in a webinar format like this, but I'm going to be asking you questions. I'll be looking for your comments on the chat box and the Q&A box. And there's going to be pop-up quizzes. When Renee said this is putting it to the test, I meant it. Get ready for some quizzes. I'm just going to see how much of basic operations management you all remember. So get your minds in gear and your fingers ready. So it'll be a bit of a refresher. And again, along the way, we'll see what some of the MHCS folks have been doing, as well as some of the COVID-related research. So before we get to this, though, I want to say we're going to have some fun, but on a sobering note, we are still in the midst of a deadly pandemic. It's led to, I know, a lot of personal loss for many of us. Of course, there's been sort of a loss of social freedom. There's been enormous economic loss. There's been emotional loss, and just the loss of people who are close to us. So it's put enormous stress on our healthcare system. And we'll get into this a little later. It's also exacerbated some of the racial and class inequalities in our society. So it's been in many ways a terrible time. And given that, we hope we're getting to the end of the worst part with the oncoming vaccines. But as a reminder, please keep physical distance for people outside your bubble. Now the latest recommendations are to wear 2 masks, a surgical mask and then a cloth overlay that creates a tight-fitting seal, and get good information. And in fact, I have a very strong recommendation for everybody. And this has really influenced the way I approach my COVID research and I understand the pandemic, and that is reading dearpandemic.org. It's operated by a group of people called the Nerdy Girls, one of which is Lindsay Leininger, who is here at Tuck and teaches in the MHCDS program. And it's a terrific website. So if you're looking for information about the pandemic and how to respond to it, Dear Pandemic is a really good source. So given that public service announcement, let's go on. All right, let's actually start with a poll. This first poll number 1, has to do with the term, which you remember from operations management, bottlenecks. Here's the question. In process analysis, a bottleneck is, and I'm going to ask you to choose all that are correct, the resource with the lowest capacity, the most expensive resource, the process step that takes the longest, the resource that determines the throughput of the entire system, or a bottleneck is something to hold on to while drinking at a party. Remember parties? Here we go. Here's the poll. And let's see what you say. And we'll get up to about 25 or so, or 30. You guys are fast. All right, good work, everybody. Let's take a look. All right, here's your results. The number one answer was the resource that determines the throughput of the entire system. Yes, okay, those of you who went through the Tuck core, whether it was with David Pike or with Brian Tomlin or Joe Hall or Eric Johnson, MHCDS me, you'll know that number 4 is a correct answer. If you read the goal, this was Jonah's point that it is the resource that determines the throughput of the entire system. Another definition that's reasonable, though, would be the number 1 definition, the resource with the lowest capacity. And we'll see that in a second. Number 2 and number 3 actually aren't necessarily true. Not necessarily the most expensive resource and not necessarily the one that takes the longest step. And we'll see why in a second. Okay, so let's take a look at what this has to do with COVID. All right, so let's take a look. So let's take a first example. And this example came up in my operations management class in the MHCDS program. This is a process flow diagram that was created by Namdi Nawachukwa, who was a MHCDS student who just graduated. And Namdi works for a consulting firm that helps pharmaceutical companies navigate the FDA approval process. And of course, you can't think of a topic that was more relevant or more urgent when the pandemic started. So Namdi created this flow diagram to show the first part of the process, the stage 1 vaccine approval process. There's a toxicology step here. There are often animal studies. Here, I'm going to draw on in color. Let's do color. I'm going to draw on my thing. There's animal studies, there's briefing books, there's meetings. These are very expensive key opinion leaders. So these are people who are experts in the field, who know mRNA, who know other things, who weigh in on the trial. These are trial designers, biologists, virologists who weigh in on it. Then later on, there's going to be some review, submission from the electronic publisher, and finally, the FDA approves or does not approve the phase 1. So where's the bottleneck? What is going to determine the throughput of this incredibly important process? Well, when Namdi looked at it, he said initially, the bottleneck wasn't the key opinion leaders. The bottleneck wasn't, say, where the toxicology reviewers were doing it. This is a very long step, for example. The bottleneck were the 4 medical writers. There were so many proposals coming through simultaneously that these medical writers, who are relatively inexpensive, who work relatively fast, they were the bottleneck. So the 4 was upped, and that created a faster flow through this part of the process. So don't be fooled. In your process, the most expensive resource is not necessarily the bottleneck. You may want to design the system so that is true, but you'll often find situations where bottlenecks are not the most expensive resources. Let's take another example. Again, from MHCDS, this was also an example that someone raised in my operations management class. This was a pop-up drive-through testing site in a parking lot near a hospital that Thad Schilling, who worked at the Reliant Medical Group, helped to study. And you can see here that there's a variety of resources. Again, resources are bottlenecks, not steps. And we have here a valet, check-in aide, nurse, and assistant. And in this case, the bottleneck was not surprising. It turns out that when he studied this system, the nurse was the bottleneck. The nurses were kind of overwhelmed, having to perform all these steps that are here in red. So what Thad did to help out is to try to move some of the work from the nurse to the check-in aide. So could the check-in aide, for example, work on the custody log, check the labels, do some of the things that the nurse did, and therefore rebalance the line to some extent and increase the throughput of the line. So in this case, the more expensive resource was the bottleneck, and we found ways to help the bottleneck. All right, the last example of bottleneck research comes from, or process analysis, comes from Emil Sohn. I'm just going to take a quick look to see if Emil is here. He was in clinic, so he could not, Emil could not make it. Okay, so Emil runs a pain clinic. And when COVID hit, they had to shift from in-person meetings, of course, to telemedicine, to online meetings. And when you prescribe narcotics that are controlled substances, there is a requirement that you meet with your patient every week. And therefore, there was no room for mistakes here. Emil had to see these patients. So he set up online a clinic, online hours, and quickly found out that what are usually 15-minute meetings with patients were turning into 20, 25, 30 minutes. So the providers were clearly the bottleneck. Things were taking a long time. And I think the first day of their online clinic, they went about 3 or 4 hours over time. It was just awful. So what they figured out again is, how do you help the bottleneck? How do you shift time spent by the bottleneck on the process to other resources? So for example, some of that provider time was spent doing things like getting the payment. So they had the medical assistant in advance contact the patients, get online, and get the insurance information and get payment information if needed. That initial reach out also doubled as a tech check to make sure that the technology was working. So that time wasn't wasted. The last reason Emil indicated that the length of time spent with patients was going up was that patients needed to talk. They were alone. They were isolated. Many were in quarantine. Some were living in tight quarters with just a few other people, and they just welcomed the opportunity to talk to someone new, and especially with their provider with whom they had a relationship. So, that was value added time, and it created a bottleneck, but in some ways it was a good bottleneck. It means that Emil and his team could do more for their patients. So again, this kind of process, the basics of process analysis, drawing the flow chart, understanding where the bottlenecks are, measuring how long resources take on each step is incredibly important. So those are just some simple examples. I've got a few more, I think, just really interesting examples of helping the bottleneck, identifying in a process where the bottleneck is, and then finding ways to help it. So the first example here, if you remember from the early days of the pandemic, there was a severe shortage of PPEs, protective personal equipment, things like masks, respirators, things like that. And it was just terrible for many healthcare providers who couldn't do their job because of shortages of this very basic resource. So one MHCDS team were running out of N95 respirators. These were the high quality respirators that would filter out the virus in their hospital. Now they realized actually that you could reuse a respirator. It wasn't officially okay, but if you could sterilize the respirator quickly, get it back on yourself, you could at least have a few cycles without destroying the material. Problem was that they were running out of sterilization equipment. So what did they do? Well, they realized that there was a nail salon across the street. The nail salon was closed, of course, because of the pandemic, but nail salons have ultraviolet lamps that are used for drying nails. And these UV lamps will sterilize N95 masks. So they actually contacted the owner of the nail salon, got inside, grabbed the UV lamps, and brought them over to the hospital. Actually, Vijay Govindarajan might call this reverse innovation, taking sort of low-tech things and elevating them for high-tech uses. So that's one great example of helping the bottleneck. In this case, the PPEs. Another bottleneck very early on were the amount of room in ICU beds, intensive care unit beds. Very, very bad shortages. Even now in some areas, there are bad shortages of ICU beds. So one hospital that MHCDS students were working at converted a general ward to be ICU beds, but there's a problem. ICU beds need to have visibility. From the corridor, you need to be able to see how the patients are doing. You need to be able to see some of the monitors to make sure they're okay. And this particular ward had opaque walls. You could not see into the rooms. So what do? you could convert from wall, you could rip out the walls and put in plexiglass. That's going to take time and be very, very expensive for what is sort of a short-term crisis. So what they do, they go to Best Buy and pick up baby monitors. Video monitors can allow them to observe, at least in the short term, how their patients are doing inside the rooms. So again, a lot of innovation. There was just an incredible creative churn in order to respond quickly to the pandemic. Those are just some interesting examples. But the higher level idea here is identify the bottleneck and think of creative ways that you can use to help the bottleneck, make sure that the system flow is as high as possible. All right. Seems I want more feedback. Hey, you know what? I'm going to give you another poll in a second. How's that? All right, here it is. Little's Law. All right, this is our second poll. Which of the following is Little's Law? And I want you to choose just one. Voltage equals current times resistance. Location, location, location. PV equals nRT. Or WIP equals throughput rate times throughput time. I'll launch the poll. Let's see what you do. Let's see. Okay, dude, it's too easy. Sorry. All right, so send the polling. Share the results. Okay, you got it. WIP equals throughput rate times throughput time. That's Little's Law. We love Little's Law, don't we? Okay, so WIP is throughput. Now, what is WIP? WIP is the number in system. It's the amount of stock you see. Throughput rate is the flow. Think of water flowing through a hose. And throughput time is how long it takes one individual unit to get through the system. So let's take a look at how this Little's Law might apply to our COVID situation. All right. Well, here's where one application of Little's Law. So if you think of WIP as the number of people in a retail store, WIP is the number in the system. Okay. And as WIP goes up, you're going to have more opportunities for transmission of COVID-19, unfortunately. And I'll talk about our model of COVID transmission in a few minutes, but this is one output of the model, which basically says, I know it's hard to read, but the average number of customers in the store, in this case, say, think grocery store, the more customers, the more interactions among those customers, the more times that they pass each other in crowded aisles, the more opportunity for transmission, even when wearing a mask. And so on the y-axis here is the average infection rate per hour. So this doesn't look high, but you get a lot of hours in a lot of grocery stores and it starts to add up. So what stores then do is think about, well, how can I reduce the WIP? How can I reduce the amount of transmission inside our store? So this is one example. This is the Walmart down in Lebanon. This is way back early in the pandemic, May 31st. They're still doing this in some hours. And basically there's a clicker and says, I'm going to allow a certain number of people in the store. I think they were allowing 130 people in the store at a time based on the square footage of the store. And when someone left, it was a WIP control system. When someone leaves, they allow someone to enter. So that's limiting the amount of WIP in the system and hopefully limiting transmission. And there were, in a variety of states, there were legal rules about what kind of density you could have in your store. All right, so Little's Law, back to Little's Law. So how do you reduce the amount of WIP? Well, Little's Law says there's essentially only two ways you can do it. All right, you can reduce the throughput rate. Well, if you're a retail store, reducing the throughput rate is not great because throughput means customers flowing through your store and buying things. So you're reducing revenue, or you could reduce throughput time. That's the time in the store. All right, so Lawrence Debo, who's a colleague of mine, we wrote an article for HBR Online early in the pandemic about safe shopping. What can stores do in order to reduce the transmission of COVID-19? Now, some of that article is informed by the mathematical model I'll discuss in a second, but we made some fairly, I think obvious and I hope useful points in that article. One is if you focus on throughput time, just make sure in-person shopping is more efficient. Help people find what they need quickly. So this may actually mean safely increasing staffing somewhat in order to get people through faster, while protecting your staff as well. Find maybe separate in your store areas in which people can very quickly come in and get what they need quickly, or even on curbside, or areas where people will browse and spend longer. So there's a variety of ways to try to reduce the time in the store and make sure that there's less interaction among customers. If you're going to reduce the throughput rate, think about how to increase the sort of the earnings per customer, increase the size of their basket, efficiently achieved, for example. And finally, you could think about ways to reduce transmission while the while the customers are in the store. And that's what our next piece of research focused on. So here is yet another poll. This is not a poll to see how well you remember operations management, but I'm just kind of curious, what have you all seen out there as you go shopping? Do you see limits on the number of people in the store, dedicated times for at-risk customers, one-way aisles, social distancing at checkout, or curbside pickup? So let's go ahead and take a look at this poll. All right, what do you see out there? We're getting all of the above. Yeah, curbside pickup, very popular. Checkout areas are particularly risky. People can clump up there, and there's some infections. We see one-way aisles, dedicated times for at-risk shoppers. Good. All right, so they're all out there, but we were curious. Some of these are spotty. Some stores are doing them, other stores are not. For example, one-way aisles, you'll find them at Hannaford's. You won't find them at the Co-op. And we were very curious why we see some of that variation here. I'll just show you the results here. So the winner was curbside pickup, but we also see all the others quite frequently. All right, so stop sharing. Let's take a look at why you might see some of them. And the fundamental question is this all for show, or does it do any good? Is it really reducing transmission, and why would it? So think about social distancing in retail stores. This is a picture at Hannaford's. You see the one-way aisle here, and there's signs on the end of the aisle saying enter here, or don't enter there. This was again early days in the pandemic in May. And the question is why? Why have one-way aisles? Why have dedicated times for shoppers? Why do these things? So what we ended up doing is creating a fairly simple mathematical model to explore the effectiveness or ineffectiveness of some of these things. I won't put up all the integrals and formulas and things like that. But if you want, the paper's coming out soon. We've posted it. I can send you a copy, but it's going to be in the Proceedings of the National Academy of Science in a few weeks. And it was joint work with Lawrence Dibbo, and then three LeBeau, Nguyen, and Annie Hohen at Geisel. They are epidemiologists who helped us to understand the transmission probabilities under various situations. And then we married that with a logistics model that allows us to understand how often people interact. And the model is ridiculously simple, actually. To be honest, actually, it was motivated by an exam I took in graduate school. It had a very similar problem on it. And basically, the idea is that you have a shopping area of length L. Think of it as a few aisles stacked end to end. And shoppers arrive according to, if you want to get into the technical details, a Poisson process, my favorite process. Basically, a random process with a rate alpha times lambda from the left-hand side. We love Greek letters. 1 minus alpha from lambda from the right-hand side. So you could have customers going in both directions or one direction. And then when they arrive, they go at varying rates. Some are fast shoppers, some are slow shoppers. The fast shoppers catch up to the slow shoppers. They pass each other in opposite directions. And we calculate how often these interactions happen. And we're allowed with alpha to play with whether it's a one-way system or a two-way system. Do we make all the shoppers go in one direction, or they go in multiple directions? So that's the basic model. It was very simple. And then we had a transmission model for COVID. There were two ways to get COVID, or at least to transmit COVID in the store. What we call direct transmission. If you come close to someone else as you're shopping, there are these heavy droplets that are falling to the floor, but could get into your eyes, on your clothes, and give you the virus. And then wake transmission. This is aerosols that are floating in the air behind people as they walk, and then are mixed into the circulatory air system of the store. So those are the two transmission models that we thanks. Sorry, I'm getting distracted by the wonderful chat line. Oh, Renee says we can cold call someone if we want. Hey, Bob, I'm going to get you in a second. Okay, so anyway, so these are the two types of transmission, and wake and direct. And if we combine those, the question is how fast. Well, first question is, if you want to reduce your chance of COVID transmission, of getting COVID, how fast should you walk? You know what? I'm gonna take. I feel like I've been talking way too much. And Renee says I can cold call someone. Hey, Bob Bat, how fast should I walk as I move through the store?
Hey, Rob.
What do you think? You're walking along. Do you want to go fast? Do you want to go slow? Like, what's the best rate of walking through a store?
I feel like this should be obvious that you should move fast, right? To do your stuff and get out as soon as you can.
Yeah, you'd think so, wouldn't you?
I would.
You would, but you'd be wrong, actually.
Shoot.
All right. That's okay, but thanks for playing. Anyway, Bob's seen this presentation before. I think he's getting. Okay, so the answer here is you want to walk the median speed, actually. In order to reduce interactions, you don't want to go too fast because then you'll pass lots of people. You don't want to go too slow; you'll get passed by lots of people. And therefore, in the middle is kind of the best rate. And I think you know this intuitively, just as you look around in a store. This is actually well known in the traffic, the automobile traffic literature. Accidents happen to people going really fast or really slow. If everyone went at the same speed, there wouldn't be such a problem. Okay, so I do want to actually make one side point though before we go elsewhere. Look at the y-axis here. The y-axis shows really low probabilities of transmission of the virus. So I want to kind of emphasize before I get too far afield that the risk for a particular individual in a retail store, you go to the grocery shopping is really, really low. All right, so I don't want to scare anyone from grocery shopping or shopping in general, although, there is a risk. I just want to point out that the risk is much, much lower than things like indoor dining. Lindsay is fanatical about for now, getting takeout or going to church or other services rather than online. These are much riskier activities. So grocery shopping, while risky, is lower on the scale. It still is important though, because a lot of people shop. All right, this is still the one activity that by and large we all do, and those numbers add up. And the latest research has shown that there have been some hotspots of COVID that are that have been brought up because of interactions in grocery stores. Actually, the fear is that the latest variants that are coming, for example, from the UK and South Africa, are so much more transmittable that even masked people in stores could be giving it to each other. I don't want to scare anyone, but again, just know that this is a relatively risk-free activity, not free, but lower risk. Still, it's something we need to pay attention to. So what did we find in the research? Well, this kind of confusing, complicated looking graph basically shows that actually one-way flow can significantly reduce what we call direct transmission. By getting people to move in the same direction, you are very in a powerful way, limiting the number of times they come in close contact with each other. So in particular, the peak here, the y-axis is the number of infections per day in sort of our model store. It looks low, but it adds up among 10,000 different grocery stores. This is two-way flow right here, and this is one-way flow. And you can see that if you look at the y-axis here, this is a 70% reduction in transmission of direct transmission. All right, so one-way flow can be highly effective. The problem, though, and I hung out for a few hours in grocery stores observing people, that in practice, people don't follow the signs, or many people. This is actually the actual behavior of people in grocery stores when you don't enforce one-way flow. And you can see that the drop-off here isn't nearly as large. So if you're going to do one-way flow, unfortunately, it does put the burden on everybody to comply, to enforce it and to do complying. So Bob, the total time in store is a function of speed. Yes, but think about walking through the rain. You go faster, you get more rain in your face. So there are sort of a countervailing things going on in terms of speed, but you're right. Going through faster can be a little better. You can see in the plot that we had earlier, it's certainly better to go fast than slow. Very slow is bad, faster is better, but median is best. All right, so that's sort of the personal thing. Okay, so we did lots of other things. I do want to get to 12:30. Good. Are we doing okay? We played with speed variance, looking at the rate at which people vary in their speeds. And not surprisingly, if you have a lot of people going very fast and a lot of people going very slow, there's more transmission per day. This is actually one, I think, interesting side benefit of these dedicated hours. I've peeked in the co-op food store here at 8:30 in the morning when they have dedicated hours for elderly people, and people are kind of going at the same rate. They tend to walk a slightly slower speed, and that means less interaction, as well as kind of separating out and grouping the more susceptible people. So that's, I think, a good argument for these dedicated hours. Even better argument for trying to get people doing similar things at similar rates. We did lots of other experiments with our model. We looked at what the impact is of spreading out the time over which people spend in the store. Early on in the pandemic, some stores actually closed their stores for longer periods of time to reduce transmission. The effect of this is to pack people together and create more transmission, unfortunately. In Europe, there are some cities that now have curfews so that they close stores at 4 or 5 to avoid the peak hour at 6. And I haven't modeled it yet, but I'm really worried that's a bad idea. Because what that does is create actually even higher peak hours, say, during lunchtime. So you want to, in general, be spreading out your capacity and reducing the number of interactions in the store. We did a bunch of other stuff. We looked for optimal throughput given the cost of infection versus the benefits of throughput. And the basic idea here, and if there's a takeaway from this complicated slide, is that this x-axis here is the disease prevalence. This y-axis is essentially the number of people you have in your store. As prevalence goes up, 2% prevalence here, it means about 2% of your population is infected, which unfortunately is not uncommon these days in some areas of the US. You want very low density in your store when you look for optimal density. But on the other hand, if you can get the pandemic under control, let it rip. The chance of infection is so low that you might as well get more flow through the store. All right, so that's a quick overview of some of the retail work we've done with COVID. Let's do a little bit else. Actually, I just got word that Emil is here. Emil, before we lose it, we were talking about your bottlenecks. Emil, do you want to just say a few things about how you went to telehealth from your original setup? Here's your flow diagram.
Oh, thank you. I apologize for being a little late. But yeah, so when the pandemic happened and our clinics shut down, we knew that we still had to see patients. I own 5 pain management centers in Southwestern Ohio. So we decided to try to consolidate to one facility and institute telemedicine for our patient encounters, particularly patients that need medication refills because those were critical. And I thought, since those were established patients and that we see them literally every month, refill meds, that, hey, this won't be so bad. We just set up an online telemedicine thing, and we could probably, turn these patients around relatively quickly at one facility. But very rapidly, the day we instituted it, it was a disaster. Within an hour, we were behind. Within 3 hours, we were extremely behind. And after lunch, we actually just stopped charting on patients entirely, just to try to catch up. And then, we ended up staying late. And then all of the providers had to chart afterwards and didn't get home till pretty late at night. It was a difficult experience. There were some unanticipated problems that we didn't appreciate, particularly the concern with technology. People didn't know how to mute or unmute their computer. They had a tough time turning on the camera. They couldn't hear well. They had low bandwidth issues. And another unanticipated issue was that people were really starved for social interaction because they had been, isolated for so long, that what I thought would be just a quick 5-minute talk to refill the meds ended up being a pretty long discussion. So the patient visits lasted a lot longer. And so this was right in the midst of Rob's class when I was in MHCDS, and I was really struggling. And so luckily for one of the assignments, we were able to make this flow diagram and map out the process. And we had come up with some ideas to eliminate some of the bottlenecks. The problem was there just wasn't enough providers or staff at certain periods. And so we sort of adjusted the flow diagram to do a pre-call or pre-check to make sure everyone's internet was working and they could hear. And then we'd collect the copay then, and then have them re-log in at a later time during their appointment. And that alleviated a lot of strain. And then, eventually we were able to identify the actual bottlenecks and fix the process. To be honest, that really isn't a type of thinking, supply chain management, et cetera, that I typically would use or need as a physician, but this ended up being tremendously helpful for me.
Thanks, Emil. That was great. That's just the really amazing thing about operations management, is that the applications just kind of appear out of thin air, all over the place. So thanks so much for letting us know about that one. That was great. All right, so let's go to, we've talked a little bit about retail stores. Let's do one last one, and then I'd love to just kind of have a more general question. Quick poll of you guys. All right, vaccines. We're all thinking about vaccines right now. I'll do a poll on vaccines. Let's see. Let's do poll 9. Let's see where you are. All right, have you been vaccinated? I've not been vaccinated. I've received the first dose. I received the second dose on time. That's through 3 weeks for Pfizer, 4 weeks for Moderna. Or I received a second dose, but I did it a bit late, say a week or two after the suggested time. Let's see where we are on that. Okay, all right, so we've got a few. Here we go. All right, so most have not been vaccinated. This goes roughly with the overall US population. Actually, we're not quite up to 20%. I think it's about 10% overall. So we've got a little higher. Some of you are, I know, MHCDS folks who are providers and have gotten it. So, but that's great that we're getting there. I'm really interested in the third and fourth category. There's a lot of uncertainty about what are the consequences of having a late second dose, and whether we really should worry about it. So let's take a look at this question. So this is Mike Gilbert's data. Mike is the chief medical officer at the Catholic Medical Center in Manchester, New Hampshire. He was MHCDS 20. And their COVID vaccine delivery from the state of New Hampshire has been all over the map. And this is actually, from what I read and hear from people, this is not unusual. The Moderna vaccine, they got an initial shipment of over 800. It plummeted to 170. then back up to 800, and just up and down. The Pfizer vaccine was even worse. There were 2 weeks of 0, and then a week of 350. All right, so very uncertain supply. And this is just, this kind of variability wreaks havoc in supply chains, and it's actually quite frustrating. And this particular havoc could be modeled with the following. Okay, so here's the last poll. You sell a perishable product with uncertain demand and or supply. You want to balance having too little of the product versus having too much of the product. This is an example of, and I need you guys to choose one. Let's see, let's go ahead and poll you guys. Here we go. Blow-up effect, Bass model, valuation model, news vendor model, or Zoolander model. Really interesting. Oh my God, I really got you guys here. This is great. All right, we'll get up to about 25. No one's taking Zoolander? Oh man. All right, here we go. Okay, well, interesting. The bullwhip effect won. No. Okay, you guys got to go back to the textbooks. This is the news vendor model. Okay, bullwhip effect is related. It has to do with information in supply chains and lagged effects. But the classic news vendor model, think about a Wall Street Journal or a New York Times trying to figure out how many physical newspapers to send. Uncertain demand, too little from the news vendor, and you do not have enough supply, too much, and you have extra newspapers. And they're very perishable, okay? So that's the classic news vendor problem. What does this have to do with vaccines? Well, on the top level, vaccine distribution is not a news vendor problem. The demand is there. We know that whatever vaccine we make now, we can sell in the sense that we can use. In fact, we're desperate to get more out there. Oh, Bam asked an interesting question. I'll get back to that in a second. In the very, the highest level abstract, where was I? You want to just produce as much as possible. Oh yeah, it is true that when you open a particular vial, you might have a perishability problem using it quickly. And that's why people have kind of find whoever they can to give the shot to. But in general, it's not a news vendor problem. But think about it this way. The complication is having first and second doses. And the juggling act is the following. If I'm the Catholic Medical Center in Manchester and I get 800 doses, and I think 800 or 1,000 doses is unusually high. If I use all of those as a first dose, this is say the Moderna vaccine, in 4 weeks, I'm gonna have 1,000 people needing second doses. And what if I only get 200 in 4 weeks? Or 300 in 4 weeks. Then I have to start delaying second doses. And the implications of that are still not clear. So Jim Smith, Annie Hohen, and I are working on a model at this point, literally today, to try to understand the first versus second dose problem. If you have a shipment of vaccines, how many do you allocate to first doses versus second doses? And we've done some very quick Monte Carlo simulations comparing basically the idea of getting shots in arms fast. Like, don't worry about it. Give as many as you can as first or second. Give priority to second doses, but give first doses wherever, versus saving some in what we call the lockbox strategy so that you always are going to give a second dose on time. And you can see just like the news vendor problem, there's a difficult trade-off here. This is the fraction of available doses administered as first doses. So 100% is basically use everything. Never save for second doses. Down here is save for second doses. And lockbox is if I give a first dose, I save a second dose, guaranteed on-time second doses. And you can see what happens is this is the average time until everyone gets their dose. The more you save, the longer it takes to vaccinate the population. So there's a consequence of lockboxes. You don't get doses in arms fast enough. On the other hand, if you administer everyone, you end up with second doses being late. This is the percentage, given the variation we saw, you can get up to half your people. If you get shots in arms, you're going to have half your people getting late second doses. Now, what's the right balance between shots in arms, which is this side, versus saving for second doses, which is this side? It's hard to know because the consequences of a late second dose is still uncertain. So we've done a variety of experiments looking at the cost, the relative cost of a delayed second dose, and seeing, given the optimization problem, what the optimal percentage of first doses to use. And how much to save for later doses. And this is literally ongoing work. We've got another meeting with Mike soon. Is Mike here? Mike, are you here? Let's see. Do we see a Mike Gilbert? Oh, he didn't make it. Okay, yeah. So, but we will. This is work in progress, and we'll hopefully get more on that later. So, I want to give. We got about 15 minutes. I want to give a quick summary, and then I'll open it up for. There's lots of great questions I know that you guys have. First of all, basic ops management has been vital for all of us in responding to all stages of the pandemic. These are the tools of process analysis, bottleneck analysis, Little's Law, news vendors, queuing. They're all incredibly important as we try to respond in a constructive way to the pandemic. I hope all of you remember to use these tools in your own work. And with that, we'll take questions. Let's start actually with BAM. Okay, BAM quickly. This was a CDC announcement yesterday. You're right. I have a daughter who has sensory issues, and getting a single mask on her is really, really hard, really tough. But they have found that basically the amount of space for airflow out of the mask makes a huge difference. And putting an elastic cloth over a surgical mask can sort of make sure that you're breathing through the mask rather than around the mask. And their tests have shown pretty impressive results for 2 masks. So if you're able to, it's always a good idea. All right, so with that, let's look at other questions. We had a question submitted in advance by Cynthia Madhu. Cynthia, are you here? I don't see Cynthia. Let's just go ahead actually and open it up. Let's see. Teodoro. With the cost of false COVID. Oh, great, Teodoro. Thank you. So yeah, Teodoro asked about false positives versus false negatives in COVID tests. This is really, really good question. Yeah, there is definitely a huge cost of false negatives, giving people false reassurance. I haven't done work on that for COVID in particular. This has been actually a particularly important question with regards to fast tests. These are tests that will give you an answer in, say, 20 seconds. They're fast, but they are unreliable. They will give you a false positive for false negatives. And it turns out there is an easy solution. That is, do repeated tests. If you get, for example, a negative, or let's say you get a positive, redo it. And when you stack the tests against each other, the probabilities of false positive versus false negative start to decline very rapidly. So there's been some interesting work on doing stacking together multiple tests using Bayesian analysis to figure out what the posterior probability of having a positive or negative is. All right, so yeah, there is work on that, absolutely. Let's see. Any other questions? I see. I'm gonna cold call somebody if I don't get a question soon.
Professor, there is one in the chat. Are there precautions put into place that you don't think are worth the effort?
Oh yeah, our model, and again, the science is evolving. We're learning a lot about this thing as we go along. But very early on, there was a lot of emphasis on cleaning surfaces. Every 15 minutes, the store would shut down and sterilize every surface. And it turns out that what's called fomite transmission, that is picking up the virus by touching a surface and touching your nose, does not seem to be a particularly common way to transmit the virus. Aerosol, airborne transmission is a lot worse. So I think a lot of effort put into sterilizing and surfaces is and some, I mean, it can't hurt, but it's sort of misplaced effort. I think it's sometimes done to some extent for show. So yeah, that's one thing that I would say. Great. Sue, actually, Sue, go ahead and do you want to verbalize your question?
Give me 1 second and I will unmute Sue. Sorry
Thanks.
about that. All right, Sue, you are good to go as long as your computer's unmuted.
Great, thank you. Wonderful presentation, very informative. Thank you so much. Obviously, for those of us who aren't qualified to deliver vaccine and give injections, are there any other areas of need in the supply chain management, if you will, for getting the vaccine out there, or are there other ways we can contribute some of the great lessons we had as in our Tuck experience to help speed the nation through the recovery in the pandemic?
That's a great, Madeline. That's a really great question. There's the obvious one, which is just help out the people around you. If there are people who need food deliveries, if there are people who are economically suffering because of the pandemic, find good, Dear Pandemic has some good suggestions for where to send money if they need it. In terms of the medical supply chain, certainly if you have supply chain expertise, it couldn't hurt to actually contact your local hospital and say, how are you guys doing? And do you want someone to come in and take a look at your chain, your processes? The most amazing questions came up in terms of supply chain. One hospital in Seattle, early in the pandemic, they got an enormous number of donations of things like PPE from, I donated my, for carpentry, I have some PPEs and I donated them, but hospitals then suddenly need to sort and understand what they have, which took a lot of effort and time. So, maybe even volunteering at a hospital and in a back office capacity to help them prepare their supply chain can help. So those are just some off the top of my head ideas. Does that help?
I have already muted Sue. I'm sorry.
Okay, that's okay. I hope that was helpful.
But Sue, please feel free to chime in the chat if it didn't answer your question. Yep,
that's great. Madeline asks, have I partnered with Dear Pandemic? I'll talk to Lindsay if she's interested. I'd love to. They work. It's funny. I'm basically an engineer, and I work at a fairly micro level. Dear Pandemic is working at a much higher level. They focus on things like inequities in the social system, in the delivery system, and things like that. But yeah, I'm happy to if they ever want to do a Q&A or anything like that, I'm happy to as well. What's the best advice for convincing mass skeptics in our families and networks? Again, I love, oh God, Lindsay and those guys have a wonderful article, and Brooke, maybe I'll try to find it and send it to you, about basically how to talk to people. What are the most, and what does the research say? And there's good research about persuasion. What does the research say about the best way to persuade people who believe conspiracy theories or don't believe basic science? And from what I remember, and this is not my expertise, but from what I remember, the basic points, some are obvious, is, do not make fun of them. Do not mock them. They believe what they believe, and listen carefully, listen empathetically, and don't try to contradict so much with facts, but just contribute in a calm way your own beliefs. Well, this is what I believe, and this is how I understand it, and just sort of try to connect on a personal level, rather than simply trying to blast someone with your expertise or what you've read in stat news or whatever. So I think those are some basic ideas. Again, there's some great research on this, on persuasion, and I think you'll find it online as well. Great.
You have a question in the chat from Amal.
Okay.
Who says, we had a lot of bottlenecks in terms of the hospital and ICU beds and ventilators. What would you suggest the government do to prepare for future pandemics to prevent predictable bottlenecks? Should we stockpile, have capability for scaled manufacturing?
Yeah, great question, Amal. In fact, early on in the pandemic, especially with regards to PPE, people were screaming about, not screaming, but they were sort of basically saying that, our push towards lean manufacturing and to our production system and so lean, make sure that the waste is stripped out of the system contributed to the problem. Because now when the pandemic hit, it was lean. We didn't have stockpiles of things like PPEs. My response is, oh my God, okay, so how many and where and what? If you're going to start stockpiling things, the next pandemic is not going to look like this pandemic in many ways. And the amount of effort and potential waste and expiring equipment when you start to stockpile is going to be really, really difficult. So Emil, is actually your question has some of the answer in it, Emil. I think the flexibility in capacity and flexibility in resources is what you want to build into your system. Lean actually is about flexibility, the ability to respond quickly to changes in the environment. That's the underlying idea of lean manufacturing. So if you think of a hospital, think about your ICU or your ICU beds, and let's say you're building a new wing with general medicine beds. Maybe think about having the walls clear. Maybe think about what are the physical parts of this that would limit our ability to quickly convert them to ICU beds, so that they're going to function as general beds, but you can have that opportunity later to flex them if possible. So that's just one example of that kind of flexibility, or as you call it, scaled manufacturing. And I think that's a great example. Emil, was that okay?
We'll wait for his chat.
That's all right.
I thought it was a great answer, Professor, and
Thanks,
he said
Renee.
it was. And with that, we are coming in on time. We are already getting so many comments and compliments about what an informative and wonderful session this was. You covered a lot of really amazing areas, and I'd just like to say thank you so much for taking the time and for such a thorough presentation. We really enjoyed it.
Thanks, Renee, and please, everyone, be in touch. I'm around if you have follow-up questions. Wait, I have a few more slides. Sorry.
Please.
Here we go. Questions. This was from Cynthia. We didn't get to that one. That's okay. Some other time. That was another one. Here we go. Other questions. And finally, thanks and be safe out there. All right, everyone, be safe. And I hope to see you in person at an alumni event or something like that. And thanks for attending.
Thank you all so much for being here. And thank you, Professor Shumsky. Have a wonderful afternoon, and we hope to see you soon.